So it gives me great pleasure to welcome to this episode of Ask the Orthodontist, Dr. Sylvia Lee. And Dr. Sylvia Lee is a dentist in Brisbane who has a special interest in release of lip and tongue tie. And today we're going to be asking her the sort of common questions that parents want to know, such as what's the deal about lip and tongue tie? Why did no one else diagnose it? And now you're telling me my kid has a problem. Secondly, once we've identified the problem, how do we release it? When do we release it? Do we need to do exercises before, during, after the release? What can I expect during the release? Is it painful for my child? What's the recovery like? All the questions that parents ask me when I identify the problem and then I refer them to you, Dr. Sylvia. So let's start. A lot of dentists seem to be well versed at looking or treating tongue tie, and that's increasing day by day. Can I ask your personal journey? How did you get into this field of tongue tie and tongue tie release?
Yes, Derek, it's such a pleasure to be here. Thank you for having me. I have always been drawn to pediatrics, all things growth and development, airway, sleep, very early on in my career. One of my strengths was that I was good at seeing children, and I quickly began getting a reputation locally for being that child-friendly dentist. So I got a lot of exposure and experience in seeing a growing mouth, right? A lot of my undergraduate training and postgraduate training in pediatrics was heavily, I would say, restorative based and surgically driven. And it was a brilliant course. But we didn't learn very much about tongue ties. And as with so many things in life, I think I was forced to look into this issue much closer and more comprehensively because of having my own son. And I don't know if the story would resonate with anyone else listening, but we had the whole works of breastfeeding difficulties. We had a super colicky baby, he was so unsettled and constipated, reflux. And I was super fortunate to have a boss at the time who was studying functional dentistry. And she, I would say, helpfully intervened and said, hey, all the stuff that you're going through right now, it seems to have a link with this tongue and lip tie. So let's have a look at it. And she organized a lactation consultant who really knew her stuff and a chiropractor, whom to that day I had no real interactions with as a dentist, but also because our issues weren't really looked at properly or I would say a bit overlooked when we were discharged from the hospital. So that's unlike, more progressive countries like in Brazil, where every single baby born by law is checked for a tongue tie before being discharged. And that's how significant this issue is for a mother and baby for the best start in life. There's actually been a very recent study done this year that concluded, it's a study done in Brazil that concluded about 30% of babies having breastfeeding issues, and then roughly about 35% of those babies having a tongue tie. Yeah, so that's interesting stats for you there. Finally, he was assessed properly and diagnosed with having a restricted tongue and lip tie, which was released. And then we were able to breastfeed successfully for over a year and a half, right? So I was able to experience firsthand the journey of an unsuspecting parent, from having all these issues totally not looked at or a bit dismissed to then seeing the right people who understand that connection and have the ability to really help. And it really switched on my interest in tongue and lip ties then. So although it was just the beginning of my educational journey on it, I was very much switched and motivated to learn more. And at the time for my own son, the active wound care wasn't really happening because of that. And fast forward to when he was a preppy, despite having breastfed so well and thriving from the benefits of that, he was still not sleeping well through the night. His posture was, noticeably getting worse. And he developed this very, very narrow and small jaw that I noticed his baby teeth were getting a little bit crowded. So I'm speaking to an orthodontist right now, but even as a dentist, we know that if you see baby teeth perfectly lined up with no gaps in between, it's a bit of a red flag for crowding when the permanent teeth come through. So, you can imagine my panic seeing these baby teeth, let alone not having gaps in between, but starting to twist and turn because of having this narrowness to his jaws. So I decided to investigate his airway and found that he had no issues with his tonsils or adenoids or anything like that. But because I had furthered my education in tongue ties over those years during that time, I was able to assess it properly again and found that he had a little bit of relapse, a little bit of residual restriction in his tongue, and a little bit of scarring that needed to be released again. So it explained why he had missed out on the upper jaw development during those toddler and preschool years. And that made me realize it's not just about recognizing the tongue tie and treating it nice and early, which really did help, but it was halfway in terms of the permanence of its result. And it's having the tongue go through exercises and stretches and the correct post-op wound care to develop muscle tone and the coordination after the surgery that fulfills the other half of the equation. And I could see firsthand the ill effects of a relapse case in my son. So the second time around, he was prepped really well by a fantastic myofunctional therapist and a manual therapist who I work closely with, and to properly prepare his tongue and his whole body for the revision. And I used the light scalpel CO2 laser and the functional method. And now he's reached a beautiful result, having that full range of motion in his tongue. His posture's better and he's sleeping significantly better in the night. So I've seen firsthand what happens when a less than ideal result ensues after a tongue tie also. And it really makes me strive to educate myself and train in this area continuously to learn what can be done differently each time to evolve and optimize the result for my patients so that A, they can get a release done properly and completely the first time, and B, for those who have experienced relapse for whatever reason, I can do revisions that yield a more permanent and functional result.
Right. And you talked a little bit there about a functional release. Okay.
Yes, yes.
Now, many parents will be in a situation where someone's identified the tongue tie and now they need to make a decision. Well, which provider is going to release it? And the first thing I tell parents, look, you don't need to have a general anesthetic to have this released necessarily. And over numerous patients we've shared, do you want to tell me why you prefer the kid to be working with you during the release?
Yeah, so it's all part of this functional release protocol, as opposed to just a simple snip or clip. So stepping back a little bit, gone are the days when any dentist should be diagnosing tongue ties based on how far the patient can stick out their tongue out of their mouth, right? It's very outdated. We've moved beyond that, and it's the least accurate way to assess for a restrictive tongue tie because it just doesn't represent what normal tongue movement is. So now we have brilliant research from all over the world to show that the normal tongue should be able to elevate up onto the palate and gently suction up there more than half the distance of fully mouth opening. And now we have this objective criteria for diagnosing tongue ties. And a good dentist should be looking at all parts of the oral cavity. And they readily do look at tongues for pathologies like lumps and bumps. And, I believe the rate of picking up oral cancer is 1 in 10,000, which is very important. But additionally, they should be looking at its function and doing like a systems check on screening patients for tongue and lip ties, which is estimated to be as high as 1 in 4 across all ages now. But the catch here is there are some tongue ties that are more hidden internally to the tongue. They used to be called posterior tongue ties, and the earlier research will use those terms, but now they're being redefined more accurately as being mid-tongue restrictions or mid-tongue ties. And these are tongue ties that at first glance look normal and seem to elevate well, but when you properly assess it, including whether or not the patient is compensating, so they might be recruiting other muscle groups outside the tongue to do the lifting, such as straining, neck muscles or moving jaw muscles. And most often, they'll be lifting the floor of the mouth up with the tongue, and that's not normal either. So a good practitioner who's well versed in tongue tie assessments will catch this and be able to determine if there is that hidden mid-tongue restriction. So step one really is to comprehensively assess the tongue, not just for how it looks, whether it's functioning normally, whether it's functioning with a compensation, or whether it's flat out restricted. Many patients come to me and say, "Oh, well, my dentist did have a little look and said it was pretty mild, so they didn't need to worry about it." But I can poke my tongue out. But they show a pretty obvious tongue restriction when we've assessed it properly the way that I've mentioned. And the thing is, having a restricted tongue tie, it really is synonymous with having webbed fingers. Or the other day, I think, Derek, you showed me a social media post where it talked about having your hands tied with zip tie or rope or something.
Yeah.
And, you wouldn't be discussing whether it was mildly tied, loosely,
Yeah.
or severely tied. And
Yeah.
to add on to that, you wouldn't be discussing if it was tied anteriorly in front of you or behind your back. It
Yeah.
just shouldn't be tied at all, right?
Yeah.
And if nobody helped you out, and if you were left like that to go about your day to day, you'll probably develop some pretty bad compensations or have the complete, inability to carry out basic functions. So there's no mild or severe tongue tie restrictions. You're either functioning normally with a compensation or you're restricted.
Yeah.
And if you're compensated, you look closely at the resultant signs or symptoms. It could be mouth breathing, poor sleep, digestion, head and neck tension for adults, poor posture, whatever it may be. You would weigh that up to see if a release is really indicated for that person. If it's restricted, you would release it for that person because he or she would have a lot of inabilities in the functions that I've mentioned.
But then again, also in my journey, I've seen some horrific tongue ties. Horrific tongue releases. Can you just tell the parents why it is that you use the type of a laser that you use or scalpel that you use? Because many parents are told, "Oh, yeah, laser's the best way to do it," and you and I know that sometimes if you use the wrong laser, you get this scar tissue, which actually can worsen the problem or at least don't fix it to the ideal. Can you just guide parents around how you would release a tongue tie to get the most efficient, minimal scarring intervention?
100%. Yes, it's an interesting one. I think a lot of it, in terms of lasers or the tool you use for the procedure, it does come down to what the practitioner feels comfortable using, of course. But for the patients, it would be beneficial to know at least the basic difference between the different types of lasers out there and ask what type of laser is going to be used. There are basically three different types of lasers used in dentistry. The most common one is the diode laser, which, in order to make a cut, the dentist needs to create a char at the end of the laser tip, and it heats up to about 1,000 degrees Celsius. It's very hot. And it's a good laser for stopping bleeding and, trimming excess soft tissue, for example, and gum recontouring procedures under local anesthetic. But unfortunately, for tongue tie releases, it does create a lot of thermal collateral damage to the remaining tongue tissue because you're physically touching on the tissue with a searing hot glass tip. You're basically searing off that tissue as you're cutting for the release. And as with any thermal damage to soft tissue, the body will respond by laying down a heap of scar tissue to heal from that. So in effect, the tongue may not be able to achieve the mobility that was the reason behind releasing the tongue tie in the first place. Not to mention, within that soft tissue is fascia with nerve endings, muscle tissue, and it suffers this thermal damage, and it can be quite painful for the patient who's expected to do these post-operative stretches and wound care massages and this post-op therapy. So it can be very painful and therefore more prone to complications as well for the patient to heal from. It's probably the one I would steer away from for the purposes of a tongue tie release for those reasons. The other type is the erbium laser, which is very powerful in cutting soft and hard tissue like bone and tooth structure. And it's not really known to coagulate or stop bleeding as effectively as it is in cutting. And it does need to cool the soft tissue as it cuts, and it does this through this inbuilt ability to spray water onto the tissue. The other laser, which is my preferred choice for my patients, is the CO2 laser. It doesn't require any contact with the tissue because it uses that true essence of a soft tissue laser technology where the beam of light is focused onto the tissue and it makes the water molecules in the cells of that tissue essentially evaporate without creating that widespread thermal damage. And it equally as effective as in coagulating as it cuts. So I just like that there's no water spraying everywhere. I have absolutely clear visibility to really select and remove the tissues that are restricted and leave behind the normal ones. And there's little to no bleeding. Scarring is kept very minimal since we aren't searing the tissue.
Yeah.
So, having an experience with all the different lasers, I personally enjoy working with the CO2. It's so clean and precise for my patients, and they're getting that full benefit of the release in part because of what I choose to use. But I also think, Derek, good work can be done with a pair of scissors, to be fair, although
Yeah.
I don't use it myself. It does the job, and it's a cold instrument, so essentially there's no thermal damage to be had. But unfortunately, there's no way to stop a bleed with a pair of scissors either. So other surgical techniques will need to be used.
And can you tell me a little bit more, to explain to the parents about the functional release method as opposed to what I would call a simple clip or snip off the tissue?
Yes. So I always like to take the conservative approach, and we never rush into surgery for tongue ties. I think, like with all surgeries, like with all surgeries in the human body, to achieve mobility, you need good prep work, pre and post operative physio, right? For example, if you have a knee surgery, after the surgery, you would want a good physio to work with you so that your body integrates properly with that new surgically treated knee. So the tongue is no different in that sense. And I work with a group of really talented myofunctional therapists or orofacial myologists, if you want to call them that. They're essentially like physios for the face and jaws, including the tongue. All my patients who have a tongue tie go through prehabilitation therapy with them as the first port of call. And this is for two reasons. Number one, when a patient does those prescribed exercises, it can really nail any muscle tone or coordination issues on the head, which for some patients completely resolves the low tongue posture problem. And so, we think that we're going to see them for the release, but after they're done with that prehab therapy, they don't need to come and see me anymore for that release, which is a lovely thing. And for the other group of patients who go through that prehab therapy and they reach this plateau of making any progress despite strengthening the tongue tone and coordination, and then eliminating compensations as much as possible, then I can release the tether with more certainty that there is that anatomical restriction that qualifies for a surgical release. The second reason is when these exercises are done properly, the fascial tissue or connective tissue becomes more organized within the tongue. And we see a lot more definition to the anatomy of that frenum when I get in there surgically. And I can see more distinct restrictive fibers to release. And the major nerves and blood vessels also lateralize. So they completely get out of the way of my surgical site and make the procedure more safer. Most of the time, also, I would add, the tongue is resting low because they have a narrow palate. And there's just simply no room for the tongue to suction onto the palate, which is often very high vaulted like this in these narrow ones. So then I'll be recommending expansion of the palate first orthodontically. And so by the time I release, the space has already been created to accommodate for the newly released tongue.
I think that's an important point. I mean, obviously, I'm coming
Absolutely.
in here with my orthodontic hat on, but I've seen so many disasters where, here's the variables. Is the tongue tie released correctly? And if it is, have exercises been done pre and post? Variable number two, so you've done the tongue tie release, but your kid can't do the exercises because they physically can't get their tongue up on this narrow palate. So I love that term that we use to our patients, which is, expand, release, retrain, like literally in that order.
Mhm.
So
Mhm.
it's important, and I'm going to get Michelle during this podcast to maybe just show parents the difference between a narrow palate and a broad palate, and how we assess that width of the palate as part of our intraoral assessment for these lip and tongue ties. But I just thought that was a really important point for parents to understand that your kid may be identified as having a tongue tie. Don't just hop in and release it. Go through the pre-functional release exercises with someone like an oral myologist. Assess with an orthodontist the width of the palate to confirm that it is the right dimension, then you kind of, yeah, form and function would follow. So that's an important point. Yeah, and
Absolutely.
can you try and explain to parents what is an oral myologist? Because I think more and more parents are seeing this in the chat rooms, and they're wondering, well, that's another person involved, and who is this person? What is an oral myologist?
So, an oral myologist is somebody I partner with very, very closely to do my work and make it a success. They're essentially like physiotherapists for the face, jaws, head and neck, and they really dive deeply into the functions of the tongue and making sure that the range of motion for the tongue, through the correct posture of the tongue, can be achieved through a series of exercises that are customized and personalized for that person with a particular oral dysfunction. That's the best way I can put it.
Yeah, yeah, and I think uh, it's a important field for me, not just in a tongue tie, but a kid who sucked their thumb for many years now has an open bite, and even though the parents are focused on the kid stopping the thumb sucking, there's still a problem now. There's a narrow palate. There's a tongue that's going forward, what we call a tongue thrust, and if you don't deal with that, again, no matter what orthodontics you do to close that bite, it's going to relapse. So I think there's a
Absolutely.
lot of parallelism and why both you and I work with such a great team of ophthalmologists. So Sylvia, we've covered. What is a tongue tie, how to diagnose it, what's a proper way to release it. Can you talk a little bit about age groups? When is the youngest you would suggest doing a tongue tie release? Is there an upper age limit?
Well, I have experience treating babies and also school-age children, early teens, early adulthood, and I've treated as old as people in their 60s. So I treat across all ages. Perhaps the age group that I really enjoy treating would be the school-age children, so 5 and above, when they're able to sit in the chair and be cooperative in the chair. If they can handle a clean and a check at the dentist, I usually am able to see them without GA or sedation.
Yeah, great. And again, if a patient wants to be able to see you, what's the quickest way? Do you have a website or a contact details that mums who are listening to this podcast maybe want to share this information to their friends and loved ones?
Yes, my website is lumicaredental.com.au, and they
Excellent,
can
excellent.
connect me through email. The email address is connect@lumicaredental.com.
Um, tongue ties, and I'll always say, if you want to know what is a bad tongue tie, listen to our current Australian Prime Minister talking. That is a good way for you to understand what is a tongue tie. Right? And why he doesn't treat it, I don't know. I think that would be a feather in your cap, wouldn't it, if the Honourable Albanese was to come and have his tongue tie released by you, Dr. Lee. But can you
It's
help
such an honor.
parents? Can you help parents understand, what is the tongue tie, and why do we need to do something about it?
Well, the tongue is a really dynamic muscle in the oral cavity. It's an organ made of 8 muscles, lots of fatty tissue, nervous tissues, and it's all encompassed in fascia. And it's essentially responsible for so many bodily functions, the obvious ones being like speech and articulation, but also tasting food, chewing, swallowing, sucking, and eating. What most people may not realize is that it does so much more than that. It plays a role in breathing, being directly connected to the diaphragm. It plays a big role in sleep, digestion, body posture. It actually assists in holding up the weight of your head in space so that you can see the world in front of you properly if it's suctioned up on the palate correctly. And this whole body connection of the tongue to the rest of the body, even down to your toes via the fascial system, it doesn't get talked about very much. Another major role the tongue plays that's very relevant to orthodontics is its nature's braces and retainer. And it literally sculpts the palate wide and broad in a child to prepare room for the much larger adult teeth that will come through later on in life. We swallow about 2,000 times a day using the tongue to lift up and create this peristalsis or wave-like motion across the palate every single time, which stimulates the palate to develop into this nice, broad, wide shape. And then it helps guide the lower jaw forwards to couple properly with the upper jaw. So it plays a major role in facial growth and development. When this connection fails, however, because the tongue is not able to posture properly up onto the palate or move correctly to stimulate the growth, we see it all the time, don't we? If the tongue is tied, 99% of the time, guaranteed you're going to have a narrow palate and all the consequences that trickle down from that, like crooked teeth and having a bad bite. So the tongue really is paramount to the growing child in developing normal jaw and facial structures that influence their anatomy and physiology later on in life, all throughout life. And there's a really great piece of evidence from a paper called The Roadmap of Craniofacial Growth Modification for Children by Dr. Audrey Yoon, who is a US-based pediatric dentist and orthodontist. And she talks a lot about the importance of tongue posture across all ages through to adulthood. And I always remember, Derek, one of your favorite sayings when you teach about how traditional orthodontics or, those factory style practices where the only thing they do is line up the crooked teeth without looking at the airway or facial structure or jaws. It's like rearranging deck chairs on the Titanic. And I love that analogy as well. What I might add to that analogy is that thinking about vessels, the tongue is so much like a rudder that directs the trajectory of the vessel. It's like a rudder, it's like a truly directing that growth and development journey of the face and jaws. But meanwhile, everyone's busy rearranging those deck chairs or waiting until the child is 12 to rearrange those deck chairs. Who's
Right.
looking at this? Who's doing the systems check and
Yeah.
looking at that potentially broken or malfunctioning rudder system of that vessel before it sets
Yeah.
sail? And our bodies are like vessels, and especially in those early years, it needs a systems check to ensure it's fit to carry out its journey. And that's where I believe the general dentists and pediatric dentists can play a huge role in ensuring every child's journey in their growth and development does not go awry. And if it does, due to poor tongue posture, mouth breathing, poor facial muscle tone, whatever it may be, they can catch it and address it early before things go too far, of course, and then redirect them back to normal trajectories. So, pediatric dentists, general dentists, who are essentially the gatekeepers of the airway and their oral physicians. No other healthcare provider looks as closely in the mouth, as thoroughly and regularly through those 6 monthly checkups than dentists do, right? So,
Correct.
I think the US are brilliant at doing this. The pediatric dentists there are all over it and are checking and screening for tongue ties, doing early interceptive orthodontics, more so than orthodontists do, it seems. And it
Yeah.
makes total sense in their position in that pediatric setting. So, the ability of the tongue to elevate up to the palate and curl back to all four corners of the mouth, it has a whole host of implications in oral hygiene, mouth breathing, which is known to be more of a causative factor in tooth decay than sugar is, sleep, developing malocclusions, TMJ disorders, clenching and grinding, neck and shoulder tension in adults. This element of what role the tongue plays in the equation is critical to be looked at in all stages of life. And I think in this day and age, 2025, I think every dentist should be looking in the mouth and be screening for this as part of their comprehensive exam.
And I just hope dental schools will have this as part of their undergraduate curriculum because I know as an educator, the first time they learn about this is after they've graduated, and sometimes 5 years after they've graduated. So then once you've seen it, you're not going to unsee it. And then a lot of these
Absolutely.
dentists say, "Oh my God, why wasn't I taught that as part of my first intraoral exam? Because for 5 years I've missed this in so many kids." So I think that's a really important point. So what we're looking at now with Dr. Lee is some research by the late great Dr. John Mew, where he looked at the type of bite you could have based on the position of your tongue and the width of the palate. Sylvia, do you want to guide people through this diagram? For those who are on the podcast, I'll be happy to enclose this as a link for you to look at if you want to review back.
Yes, so this diagram essentially illustrates one of the main functions of the tongue in dentofacial, growth, and especially in a growing child. Up until the age of 6, it is possible for the tongue being suctioning lightly onto the palate fully. So not just the tip of the tongue, but the whole posterior body of the tongue, or the mid-tongue we say now. If it's suctioned onto the palate, we can organically expect the palate to grow nice and broad and wide. And this diagram is showing sort of the different types, different widths that can be achieved depending on how the tongue is present in that palate space. And so, if it's against the palate fully, like in this first diagram here where it says ideal occlusion, you're going to expect the width of the palate to be normal or ideal to be able to accommodate for all of the permanent teeth that come through later on in life. And then as you go down the scale down to number 5, you can see that the tongue position is very, very low, and it hasn't been stimulating the upper jaw correctly. And so by the time the adult teeth come through, there's essentially no room, and you end up with orthodontic issues such as a posterior crossbite, narrow jaws, and a whole cascade of orthodontic problems like dental crowding also.
Great. And I just want parents to understand that there's 3 factors at play here. One is the width of the palate that Sylvia's already discussed. The second is the position of the tongue. And the third, as this diagram illustrates, is that tongue tie. And if that tongue tie is present, you're not going to be able to get that tongue into that ideal position number 1. What Sylvia and I look at routinely when we do our intraoral exams is we look at the classification of ankylosglossia. Ankylosglossia comes from the Greek, glossia being the tongue, and anklo being the tie, right? So if you look at normal, what we call grade 1, grade 1 means that the patient, when they fully open their mouth, they can get their tip of their tongue 80% or greater, almost to what we call the spot, without closing their mouth. Grade 2 is where they're greater than 50%, but not quite greater than 80. So 50 to 80 is still what we would call functional, but not ideal. Where we start talking about needing something done is below the 50%. So grade 3. And the obvious one that I always say Helen Keller could pick up is the grade 4, right? And it'd be nice but having said that, Sylvia, do you know how many patients you and I see who are 8, 9, 10, 20 years old and have a grade 4 and no one's even picked it up? It's crazy, right?
That's right.
And
That's right.
yeah. So that's just a diagram I wanted parents to kind of be able to do. So remember, the hot tip is anyone can cheat and have grade 1 if they close their mouths. In other words, if that range of motion of opening is not as wide as it can be. So that's why parents sometimes say, all right, Johnny, put the tip of your tongue up on your palate. And Johnny will do that, even though he's really badly tongue-tied. Why? Because he's not fully opening as he stretches the tongue. And the other thing I like doing is I like putting my finger on the floor of the mouth so that they can't cheat and lift the floor of the mouth. That gives you a more accurate reading. Now, there was one video that I think is also good, and I'll just kind of this is all the stuff, Sylvia, that I'm constantly, using at consults for parents. Okay. Now, this is the video that was put together by Dispatches when John Mew did his interview. And maybe you
Do you want me to speak now? Derek, am I supposed to be speaking?
Now, Sylvia,
Yep.
I just played the video for Michelle, and I'm not sure that audio will come up. Do you want to talk through that again? So what we're showing here is what Dr. Lee and I are examining every day, and if we could see every kid having a beautiful broad jaw like this, that'd be fantastic. The second thing is, the tongue should sit inside those teeth. Sylvia, tell me what you see when sometimes you ask the kid to raise their tongue on the palate. What happens?
So in a narrow palate, it's a sure sign for me that the tongue was never really there to sculpt and broaden the palate in the first place during those early years of development. And so by the time a child comes to see me with such a narrow palate as you see on the screen there, there's usually an inability or the tongue is so tied down to the floor of the mouth that even if we ask the patient to lift up, either they can't or they are compensating with other muscle groups to get that elevation, which is not normal. Both are not normal. And, this is where we see the teeth coming through, the permanent teeth are just all rotating and twisting and turning to try and fit into this very narrow foundation that unfortunately didn't receive the stimulation of broadening with the tongue being normally positioned. And then the other thing we need to think about is the power of the cheek muscles, which, it's usually needing to be compensated by balanced out, I should say, by the tongue being up on the palate again to again withstand the forces of the palate narrowing from the outside by the cheeks. So the tongue really shapes and directs a child's growth and development in the oral cavity and the whole facial structure as well. So that's the reason I call it like the rudder system of a vessel. It really directs the trajectory of a child's craniofacial growth and development. And when they grow up to become adults, such as in this picture, you can really pick out the faces that have been stimulated to the full extent and have expressed fully the capacity of the tongue to really sculpt the face nicely forward in the mid-face area, and then coupling that lower jaw to match with the nicely developed upper jaw, as you can see in that left side face with the man with a really nice broad arch. And it really does unfortunately show when you look at a face that is really not developed in that mid-face region. The chin is really retruded, and then you get that lack of that jaw angulation, the contour of the face. You can really tell when the face is not fully developed, that the tongue really wasn't there posturing correctly up on that palate to direct and sculpt the face forward.
This one here, Sylvia, is what I like to talk to the parents about, posture release, what we're aiming for. And when the tongue sits on the palate, it is away from the back of the throat. So it gives that kid that nice airway.
When the tongue is posturing correctly, suctioning up onto the palate fully, so not just the tip of the tongue, but the whole body of the tongue, suctioning gently up onto the palate, what it does is it creates a passive seal against the soft palate. And in turn, it creates a lot of room behind the oral cavity where the airway is. So it's the velopharynx area, and thereby it doesn't hinder the patency of the airway in that person. If the tongue is not correctly positioned, because of whatever reason, due to a habit or not having enough tongue space, having a tongue tie, that suction cannot really establish with a soft palate, or just the posterior aspect of that tongue drops behind the oral cavity, and it ends up occluding fully or partially occluding the airway, especially when that patient lies back to fall asleep.
Perfect, perfect. And I think the last thing we do, Sylvia.
Okay, so
Yep.
this is a diagram of the deep front line. It is the fascial tissue that goes from the tongue as one continuous piece through the diaphragm, through the pelvis, through the knees, all the way down to the toes. It's like one very stretchy, thin bodysuit. And if any part of this system, the deep front line, is pinched or restricted, it can directly affect through this concept of tensegrity, where the tissues directly affect in one area another area. And so the same goes for a tongue tie. If you are tongue tied, the effects of having that organ restricted in its mobility and posture, it can directly have compensatory effects that are negative to other parts of the body through this deep frontline fascial system.
Perfect.
I was going to say, a good what makes a functional release method what it is that when I do the release, the patient is very much awake and are able to assume a suction hold, and I make sure that the whole body of that tongue can lift onto the palate while I'm releasing that tether completely before I finish off. And for the very, very severely, restricted tongue ties, that may take 2 stages to accomplish, with a period of myofunctional therapy in between, so that the deeper fibers have some time to come through, and then we can get the job done more completely in that second stage. And then finally, just making sure that the tongue is well rehabilitated by the post-op myofunctional therapy. It takes about 6 months to a year for the connective tissue to fully remodel after a release. So to prevent any relapse or optimize wound healing, it's really important, I would say, just as critical as the surgery quality itself, for the patient to actively and diligently engage in that rehabilitation phase of treatment. And a good research paper was done on this method, which has recently been updated, I believe, to show even better results, by Dr. Zagi in the US, who showed that a release combined with myofunctional rehabilitation consistently and significantly improved outcomes in tongue-tied patients. And we now also have a protocol for monitoring and objectively assessing the wound healing phase of treatment now. And I routinely do this at my various review appointments post-op, and take appropriate measures according to how that particular patient needs support in their healing and remodeling journey. So really, no one should be having a simple snip or clip to this very dynamic organ of the body, which the tongue is, and then being told, off you go, all the best. And I'm sure all practitioners would agree, whether they perform this procedure themselves or refer on to others, that their patient deserve the very best. And the gold standard now is this level of comprehensive approach that, as you can see, is really multifaceted and multidisciplinary.
Perfect.